Yeah, hello guys. Good evening, all of you. Namaskar, good evening. So, welcome you all for this class. In this class, we are going to revise autocoids through these MCQs. In second year course, our target every month we discuss MCQs of one topic. General Pharmacology is over, ANS is over. Today, we are going to discuss about the autocoids. So very important topic, short topic, but very important. Lot of questions. All the NSAIDs, prostaglandins, histamine, serotonin, and related drugs we are going to discuss. Okay. So I hope it's audible and visible. Okay. So questions. Okay. So let's start. Chaliye. So the question number 1. Mr. Rahul was prescribed a first generation H1 antihistaminic drug. He should be advised to avoid driving motor vehicles, consuming processed cheese, or strenuous physical exertion, or all of the above. So guys, what do you think? क्या करना चाहिए? So as you know, the patient you prescribed first generation H1 antihistaminic. So whenever we talk about first generation H1 antihistaminic drug, remember H1 receptor is one of the histamine receptor. The histamine receptor is GPCR type of receptor. The role of H1 is for allergy. There is vasodilation, bronchoconstriction, rash, itching, urticaria, all these actions due to histamine. Antihistaminics block these actions. So basically these antihistaminic drugs are used for anti-allergic medicines. Patient is having allergy, cough, cold, you give these drugs. But simultaneously you need to advise something. So what advice you will give to this patient? Because when we give the antihistaminic, always and always remember the side effect of this antihistaminic. When we talk about the important side effect of antihistaminic, there are two important side effects of antihistaminic. One is when you reach these, when these drugs are given and these drugs are reaching to brain, these drugs can cause sedation. Because histamine causing alertness, antihistaminics causing sedation. So the drugs which are lipid soluble can reach to brain and they can cause sedation. The second important is these drugs are having anticholinergic activity. These drugs are having anticholinergic activity, so there will be anticholinergic side effects like dry mouth, constipation, blur vision. These problems will be there, atropine like effect. So first generation and second generation. When we talk about the first generation is more lipid soluble. Second generation is the metabolite of first generation, so they will be less lipid soluble. Because the second generation is less lipid soluble, they have less sedation. Also, second generation not having anticholinergic side effect. So these side effects are seen with the first generation mainly. So because of this, whenever we give the first generation antihistaminic like promethazine, diphenhydramine, we should advise the patient for avoiding the motor vehicles, because drivers, the person who need constant attention, and there is risk of sedative with the first generation. Which drug you can advise for these patient? The drugs which are not sedative you can advise to these patient. The drugs which are not sedative you can advise to these patient. So in the non sedative drugs we have the second generation, or you can say we have the third generation. Nowadays third generation drugs are available which are least or non sedative drug. Always and always remember first generation के साथ में ड्राइविंग को अवॉइड करना है. क्लियर है? So can you tell me cetirizine और cetirizine ड्रग बताओ पहले. Cetirizine is first generation, second generation. What do you think? What do you think बच्चों? Cetirizine is first generation, second generation. तो cetirizine किस में आएगा? Is it first or second? Because cetirizine is commonly prescribed anti-allergic drug. किस में आना चाहिए? Waiting for your comment. And then we'll discuss the next question. Which of the following drug if given with terfenadine, can cause ventricular arrhythmias. Again, important question. So cetirizine is second generation antihistaminic. That's what is commonly prescribed. It is having very good effect as well as less sedative. But nowadays, third generation antihistaminics are available, like levocetirizine, that is the derivative of cetirizine, fexofenadine, that is derivative of terfenadine. So these are some third generation. Loratadine to desloratadine. So these third generation, they are non-sedative. So that's why non-sedative drugs are available in the market. These are third generation. So terfenadine, that is also one of the antihistaminic. That is second generation antihistaminic. So remember terfenadine and estamazole. These two drugs are important. Terfenadine and estamazole. These two drugs are H1 antihistaminic drugs. These two drugs are H1 antihistaminic. And both these are second generation. Both these are second generation. So they are less sedative. They are more polar. But these drugs are having the risk of QT prolongation. And this type of arrhythmia is called as torsades type of arrhythmia. Torsades de Puentes. So torsades type of arrhythmia due to terfenadine estamazole. That's why these drugs have been withdrawn from the market. These drugs have been withdrawn. तो 3 drugs याद रखनी है. CAT, CAT, C for cisapride, A for estamazole, and T for terfenadine. Cisapride, estamazole, terfenadine. These drugs are having risk of QT prolongation, torsades type of arrhythmia, polymorphic ventricular arrhythmia, lethal, dangerous, patient may die. So these drugs withdrawn from the market. Already these drugs are withdrawn, but one interaction was also important with this. The interaction is कि sir, these drugs like terfenadine, estamazole, these drugs metabolized by CYP3A4 enzyme. That is a common type of CYP in general pharmacology we discussed. So the drugs which are CYP inhibitors, these CYP inhibitor drugs slow the metabolism of these drugs. So they increase the toxicity risk. And what is the toxicity? Arrhythmia. So we need to find out of these drugs which is CYP inhibitor and which can increase the risk of this type of arrhythmia. That type of drug should be avoided with terfenadine estamazole. But nowadays they are not available in the market. Then why this question is important? Because sir, history is also important. कि क्यों गए मार्केट से, क्या सीखा आपने उससे. तो out of these you can see the drug which is CYP3A4, because that is the most common CYP3A4. So out of these ketoconazole, general pharmacology. तो यहाँ पे you have to mix the knowledge of autocoids as well as general pharmacology, and then you will get the correct answer. Ketoconazole is CYP inhibitor, griseofulvin is CYP inducer, rifampicin, griseofulvin, CYP inducer. Ampicillin is not CYP inducer inhibitor. Amiodarone is inhibitor but not CYP3A4, not a universal inhibitor. So that is not important. That is mainly important in warfarin we'll discuss. तो ketoconazole बच्चों, ketoconazole या फिर you can say cimetidine. These drugs are which are CYP inhibitors. They can cause problem. Azithromycin, they can cause problem. So risk of QT prolongation. Fexofenadine is the metabolite of terfenadine, and that's why fexofenadine is third generation and that is non-sedative drug. So the answer in this will be ketoconazole. Okay, let's see the next question. After taking some drug for acute attack of migraine, after taking drug for acute attack of migraine, a patient developed nausea and vomiting. He also developed tingling and numbness in the tip of most finger. that also turned blue. This finger also turned blue. Which of the following among us is the most likely implicated in causing the above finding? So, which drug out of these having this problem? First, we need to find out which is the drug for acute migraine. In acute migraine, aspirin can be used. Yes, it is one of the NSAIDs, so definitely can be used. Sumatriptan, yes, that can be used. Ergot compound, that can be used. Butarphenol is one of the opioid that can be used. All these drugs can be used in acute attack of migraine. Now we need to see out of these drugs which can cause nausea, vomiting, tingling, numbness and also turned blue. If the finger turned blue, tingling, numbness is there, that means the drug which is causing end artery vasoconstriction. The drug which is causing end artery vasoconstriction. In the tip of finger, tip of toes, if there is end arteries, there is vasoconstriction. These drugs can cause this type of problem. Now, out of these, aspirin is not going to cause this problem because there is no direct effect in these periphery blood vessels. Butarphenol is the opioid that is also not causing this type of problem. But dihydroergotamine and sumatriptan, these drugs, dihydroergotamine and sumatriptan, these drugs are acting on 5-HT receptor. And 5-HT agonistic action will cause the end artery vasoconstriction. So these are having the risk. But now we need to find out which is having more risk. So out of these, triptans are more specific for 1B/1D. 5-HT 1B/1D. That is a specific drug. Selectivity is there. But dihydroergotamine is non-selective 5-HT1. Non-selective 5-HT agonist. So that's why these ergot compounds are having the more risk. So ergot compounds are not selective for 1B, 1D, 1F. They have the effect on all 5-HT receptors. That's why non-specific, non-selectivity, they have the risk. Sumatriptan is having less risk of end artery vasoconstriction. That's why that is a preferred drug of choice. So ergots are having same effect, but because of side effect, they are not the preferred choice. But can you tell me then why they are used in India? हम क्यों यूज कर रहे हैं? If ergot compounds are risky, but why they are still used? क्यों यूज कर रहे हैं बच्चे? क्या क्या बेनिफिट क्या है? मतलब ऐसा क्या है कि आप अभी भी यूज कर रहे हैं? Why we use the ergots still, even though we have the better option triptans? I gave you the hint कि India, developing country, why we still use? Cost, सस्ता, cheaper. Okay, let's see the next question. Which NSAID undergoes enterohepatic circulation? Which NSAID undergoes enterohepatic circulation? When we talk about enterohepatic circulation, means the drug is going to secrete in the bile, and through the bile it goes to stool, and then it is going to excrete. So definitely these type of drugs are safer in kidney patients comparatively. Now we need to find out which drug out of these goes in enterohepatic circulation. Phenylbutazone, aspirin, ibuprofen, they are not going to excrete via bile. Out of these, piroxicam is the drug which is going in enterohepatic circulation. But here I also give you one important task. See what happens. First, piroxicam is going to phase 2 reactions, and that is the conjugation reaction. There is no phase 1. There is no catabolic reaction. It goes to phase 2 reaction, conjugation reaction. So it is goes to conjugation. After conjugation, this conjugase is secreted in the bile. Through the bile, definitely it goes to intestine. In the intestine, we have the bacteria, and these bacteria, they have deconjugase reactions. Deconjugase reactions. These bacteria are having the deconjugase reactions, and because of this deconjugase reactions, what happens? Piroxicam is again free, and this piroxicam absorbed in the intestine, and because of this piroxicam absorption, again now it is in the plasma and it is causing the effect. So this is recycling, you can say, and because of this recycling, this drug is longer action. This drug is longer action. So why piroxicam is the longest NSAID? The reason it is longest is because of enterohepatic recycling. No phase 1, only phase 2 conjugation reaction. This conjugates secrete in bile, reach to intestine, intestine bacterial deconjugase enzyme. Again piroxicam is free from this conjugates. This piroxicam is reabsorbed and then it is causing the effect again. So that's why recycling process is there, and that's why piroxicam is longer. Now just imagine estrogen also having same process, estrogen. That's why estrogen is also longer. But if I give the antibiotic, then what happens? If this person I give antibiotics, the drugs which suppress the bacteria, this antibiotic will inhibit this bacterial deconjugase. If I give the antibiotics, broad spectrum antibiotics, they suppress the bacteria in the intestine. If you suppress the bacteria in the intestine, what happens? If you suppress this bacteria in the intestine, there is no deconjugase. If there is no deconjugase, there is no recycling. If there is no recycling, it cannot have the longer action, and that's why it is not very effective. So piroxicam should not be prescribed with antibiotic. This is the reason. So pyrox is a good drug, good analgesic, longer acting, 24-hour action. दिन में एक बार देना है, once a day. But we should avoid using this drug with the antibiotics, otherwise it is not longer. So that is the important task. The same reason with OC pills, if you use the antibiotic, the same problem happens. चलिए next question. A 3-year-old child present to OPD with the symptoms of influenza. Influenza is one of the virus. Aspirin is contraindicated in this patient because of, very simple question, but one of the very, very, very important topic. Every doctor should be aware about this. That's why in second MBBS definitely we need to know this. So why the person who is a child, the patient who is a child having viral infection. So in the children having viral infection, we should not use aspirin, because in these viral infection, children where the liver is not very strong, if you give the aspirin, there is risk of hepatic encephalopathy, because liver is not strong. The risk of encephalopathy, hepatic means liver, encephalopathy, so risk of hepatic encephalopathy, and this is called as Ray's syndrome. So why aspirin not safe in children? Because of Ray's syndrome. What is Ray's syndrome? That is hepatic encephalopathy when aspirin is used in viral infection in children. So बच्चे, if I ask you which drug out of the NSAID can be used safely in children, what is the alternate of aspirin? क्या alternate है aspirin का? क्या use करना चाहिए बच्चों में? What is the alternate of aspirin in children? The alternate of aspirin in children is ibuprofen. Ibuprofen is safe. paracetamol is safest. So simply analgesic, then PCM. But if you need anti-inflammatory, then ibuprofen is also safe option. So the other drugs which are very safe are PCM, ibuprofen, but aspirin is not safe. Okay. Next question. A college student is brought to the emergency. College student brought to the emergency after taking overdose of a non-prescription OTC drug. The patient is confused and lethargic. He has been hyperventilating, dehydrated. ABG arterial blood gas analysis demonstrate metabolic acidosis. In the management of this patient, which is not likely to be of any therapeutic value. In the management of this, which is not likely to be have any therapeutic value. College student, emergency, overdose of non-prescription OTC drugs. So these analgesic drugs like PCM, ibuprofen, aspirin, they are available over the counter. This patient after this overdose is confused, lethargic, hyperventilating. So this is hyperventilation, and because of hyperventilation, what happens? CO2 washout, and this CO2 washout leads to respiratory alkalosis. Body will try to retain the acid. That's why there is metabolic acidosis. So this is typical situation where respiratory alkalosis, metabolic acidosis. This condition is called as salicylism, and this is called as aspirin overdose. Aspirin overdose is called as salicylism. More than 15 gram of 15 to 20 gram of aspirin, salicylism, salicylate poisoning. Aspirin, when aspirin is given, aspirin is having faster absorption in the stomach. Gastric lavage is not of any value. We should have the lavage is not having any significant role. That's why there is no specific role. Naloxone is the antidote for opioid, not the NSAID. Now, correction of metabolic acidosis. Yes, you should correct it. Alkalinization of urine. Yes, we should do by giving the soda bicarbonate. So that is important. But now we need to see the question. We need to select one answer only. So not likely to be of any therapeutic value. So you may say, कि sir gastric lavage may be done. I told you there is no significant value. If they ask you the question, is gastric lavage useful? Not very useful. Not very useful. But out of these, if you ask me, कि sir, is having any therapeutic value? Yes. Yes, any therapeutic value? Yes, thoda bahut to hai. But there is no role of naloxone. That is not the antidote for aspirin. So that's why the correct answer will be this one. But if they ask you in opposite way, कि gastric lavage is useful in, then it is not very useful in salicylate poisoning. So we give the soda bicarbonate. If not control, then hemodialysis can be used. Remove the salicylate by dialysis. But naloxone is for opioid, not for aspirin. So don't forget, aspirin will have hyperventilation, respiratory alkalosis, metabolic acidosis. In very high dose, aspirin can suppress the respiratory center and the patient may go to respiratory failure. If respiratory failure, then it starts CO2 retention, and then there will be respiratory acidosis. So there will be respiratory alkalosis, metabolic acidosis, and in very high dose, when the respiratory centers are depressed, then there will be respiratory acidosis. Okay, next question. The antidote of choice in paracetamol poisoning. Very important question, paracetamol poisoning. In paracetamol poisoning, initially 24 hours you will not see any symptoms. If the patient is having more than 150 milligram per kilogram, सोचिए patient is having more than 10 grams of paracetamol, then it is poisoning. If more than 300 milligram per kilogram, then it is severe poisoning. In this case, gastric lavage is useful. In this case, gastric lavage is useful. Give the charcoal, activated charcoal. In this case, give the antidote, but antidote should be given early. If you give the antidote early, then only it is effective. Otherwise, it will not be effective. We should give the antidote as early as possible, at least within 4 hours, 8 hours, 12 hours, but not more than that. That is N-acetylcysteine. So this is useful, this is useful. Flumazenil, that is the antidote for benzodiazepine. Sodium bicarbonate, that is the antidote for acidic drugs like aspirin. Fomepizole, that is the antidote for alcohol, methanol, ethylene glycol. N-acetylcysteine is the antidote for paracetamol. So what happens when we give the paracetamol? This paracetamol is going to convert into NAPQI, N-acetylbenzoquinoimine, and it is going to change in the non-toxic metabolite. This is glutathione peroxidation, glutathione mechanism, and this is CYP 2E1. So this is the reason when we give this N-acetylcysteine NEC, the role of this NEC is to replenish this glutathione. When the glutathione replenish, this non-toxic metabolite will increase and the NAPQI will decrease, because NEC replenishing the non-toxic metabolite, this glutathione. That's why non-toxic metabolite formation will be more. NEC also binds to NAPQI. NEC also binds to NAPQI and decrease the risk of central necrosis of liver. That's why in both way it is helping the paracetamol poisoning patient. So the best antidote will be N-acetylcysteine. Next question, allopurinol potentiate the action of corticosteroid, colchicine, 6-mercaptopurine or ampicillin. Allopurinol, a drug which is inhibiting xanthine oxidase enzyme used in chronic gout patient. Because it is xanthine oxidase enzyme inhibitor. Now we need to see out of these there is a drug, you can see mercaptopurine, because the role of xanthine oxidase, what is xanthine oxidase role? From the purine there is uric acid, means from the DNA uric acid. This is xanthine oxidase and you are inhibiting this process. So you can see 6-mercaptopurine. So that is a purine. When you see this 6-mercaptopurine, it is also metabolized by xanthine oxidase enzyme. So basically some drugs which are purine analogues, like 6-mercaptopurine, azathioprine, these are purine analogues, and these purine analogues are metabolized by xanthine oxidase enzyme, like 6-mercaptopurine, azathioprine. These are immunosuppressants or anti-cancer drugs. These are purine analogues. They are metabolized by xanthine oxidase. You can see this drug inhibit the xanthine oxidase enzyme. If the allopurinol inhibit the xanthine oxidase enzyme, the effect of this drug will be more. and that's why the dose adjustment is must. The dose of these drugs need to be decreased with allopurinol. So with allopurinol, the dose need to be decreased, otherwise these drugs will be toxic because the effect of this drug will be more. So this is the reason 6-mercaptopurine, azathioprine dose need to be decreased, because allopurinol can potentiate the action of these type of drugs. Very important drug interaction in explain why type of question or in MCQs. This is very important, they are asking. Next question, very simple question. Most common cause of Mobius syndrome. There are many drugs which are causing the Mobius syndrome. Is use of which of the following drug in pregnancy? So first we need to know what is Mobius syndrome. So it is the abnormal development of sixth and seventh cranial nerve of fetus. Abnormal development of sixth and seventh cranial nerve of fetus. Sixth is abducent nerve, that is for lateral rectus. जिसकी वजह से you can see right or left without movement. So this is lateral rectus, LR6. Lateral rectus palsy, sixth nerve. Seventh nerve, that is for facial expressions. So this smile is due to facial nerve. So these are abnormal development. So this child is having these problems if the mother has taken the misoprostol during pregnancy. So that is the teratogenicity. That is the teratogenicity. Even thalidomide can cause this problem, but mainly it is the drug which is misoprostol PGE1 analog. Usually it is causing abortion, but if not abort, then this risk is also associated. So misoprostol is the correct answer. Next question. The drug which block H1, 5-HT2 and muscarinic receptor is. So blocking the H1 receptor, blocking the 5-HT2 receptor, serotonin, blocking the muscarinic receptor. So we can see that there are some drugs which are H1 antihistaminics. If they are first generation antihistaminics, they can also block the muscarinic receptor. I told you first generation antihistaminics are having the anticholinergic property. The M blocker means anticholinergic. But this drug is additionally having serotonin blockade property. So first we need to see out of these which is antihistaminic. Ondansetron is 5-HT3 blocker, so that is not antihistaminic, that is serotonin blocker for anti-emetic purpose. Cisapride is 5-HT4 agonist, that is for prokinetic purpose, not for antihistaminic purpose. तो एलर्जी की दवाई नहीं है. Flibanserin is also acting on 5-HT2 receptor. It is 5-HT2 receptor 2A 2C antagonist. But cyproheptadine is the drug. This cyproheptadine is the drug which is mainly 5-HT2 antagonist, but additionally it is having antihistaminic and antimuscarinic property, and that's why it is used for all three purposes. So it is the antihistaminic, so used in allergy. It is M1 antihistaminic, so it is the first generation antihistaminic. Anticholinergic with antihistaminic. Because it is 5-HT2 blockade, that's why it is used in migraine. It is also used in the patients where you want to increase the appetite. Because if you block the 5-HT2A 2C, mainly 2C, then appetite will increase. So to increase the appetite, as well as this cyproheptadine is the drug. It is used for migraine prophylaxis. It is used to increase the appetite and can be used to treat the serotonin syndrome. In the patients who have the serotonin excess, you can give this cyproheptadine. तो इन कीमोथेरेपी पेशेंट्स टू इंक्रीज एपेटाइट, बट नींद बहुत आती है बिकॉज इट इज हाईली सेडेटिव बिकॉज ऑफ एंटीहिस्टामिनिक, ड्राई माउथ बिकॉज ऑफ M1 ब्लॉकर। चलिए नेक्स्ट क्वेश्चन, अ पेशेंट डायग्नोज्ड विद रूमेटॉइड आर्थराइटिस वाज ऑन मेडिकेशन, patient was diagnosed with rheumatoid arthritis, was on medications. After few years he develops bull's eye maculopathy, he develops bull's eye maculopathy and was found to have the corneal opacity. The bull's eye maculopathy is like this, one light ring, one dark ring in the retina. This is bull's eye appearance, this is bull's eye appearance. So when the patient is having bullseye, corneal as well as corneal opacity, which drug is most likely to cause this? The drug of rheumatoid arthritis. When the drugs used in rheumatoid arthritis, these drugs are called as DMARDs, disease modifying anti-rheumatoid drugs. They slow the progression of the disease modifying anti-rheumatoid drugs. So first you can see all these are DMARDs. All these are DMARDs, all these are hepatotoxic as well. All these are DMARD, all these are hepatotoxic drugs as well. But out of these drugs, specifically in the eyes, hydroxychloroquine or chloroquine. This drug regular use because it is having high affinity for retina, and this drug is having highest volume of distribution, so can reach to these tissues easily. Even though it is having more affinity for liver, so mainly in the liver, but also reaching to eyes. So hydroxychloroquine, that's why regular ophthalmic examination required when we use chloroquine, hydroxychloroquine for long-term purpose. When we use for short-term like in malaria and all, then no worries, only gastritis, gastric problems are main. But in the, so please see the image also, कभी कभी image पे MCQ आता है in the NEET PG exam, तो you can check the image. Next, which antihistaminic drug is best to be used? Now I have given some clinical question from the same topic. Is best to be used during daytime because of least sedative potential. I already gave you the idea. These are third generation antihistaminics. They are pure water soluble and they are non-sedative drug. And only three important third generation drugs are available in the market. One is fexofenadine, that is the derived from terfenadine. One is levocetirizine, that is the derivative of cetirizine, and desloratadine, that is the derivative of loratadine. So these FLD, fexofenadine, desloratadine, levocetirizine. So out of these, fexofenadine is the correct answer. Promethazine first generation, cetirizine is second generation. So non-sedative, fexofenadine, levocetirizine and desloratadine. Okay, don't forget. Next question, what is true regarding aspirin are all except? About aspirin, we have discussed about aspirin, so all are true except, let's see the options. Rage syndrome in children, that is true. I told you hepatic encephalopathy when used for children having viral infection. Decrease efficacy of diuretic, that is also true because diuretics are acting via prostaglandins. Prostaglandins causing increase in GFR, urine output. So this is the effect of diuretic. When we give the aspirin, they decrease this prostaglandin, and because of this GFR will be reduced. So that is also true. So aspirin or NSAIDs can cause the decrease effect of diuretics. Also antihypertensives, because they decrease the vasodilation due to prostaglandin. Phospholipase inhibitor, that is false. Phospholipase enzyme is inhibited by the steroids, that is the steroids. Low dose aspirin need not to stop before minor surgery. The true low dose aspirin which is used for antiplatelet purpose. The guideline says ki no need to stop because that low dose aspirin is not causing the risk of bleeding. High dose can have, but low dose is safe. That's why the correct answer will be C. So aspirin is non-selective COX inhibitor. Aspirin is non-selective COX inhibitor. Non-selective COX inhibitor. In low dose, it is only COX-1 inhibitor. But otherwise, in normal or high dose, it is non-selective COX inhibitor, and that is also irreversible. That's why eat and run. Next question. A patient is on treatment of acute migraine attack. Now, this is one of the PYQ in NEET PG exam. Now he develops numbness and tingling on the tip of finger. I already told you the reason in one of the MCQ. Migraine is very important. Which drug is responsible for this and the drug used for the treatment? So both these conditions, both these drugs have been asked. The drug causing the problem and the drug used for the treatment. So first we need to see the options. Sumatriptan, ergot, propranolol. So first we need to see that all these drugs can cause vasoconstriction. Even though propranolol causing vasoconstriction, that is a beta blocker because of risk of alpha effect causing vasoconstriction in the body. But this is not possible in the answer because the question is about the acute migraine. And in acute condition, we don't use propranolol. Propranolol is the drug for chronic prophylaxis. Now, out of ergot and sumatriptan, you know it is the ergot. And why amlodipine? Because amlodipine is a calcium channel blocker which can cause vasodilation. So because of this, you can use the amlodipine, sodium nitroprusside, these drugs as a vasodilator for the treatment of this condition. So the drug mainly causing this problem is ergot, but the drug which is used for the treatment in peripheral vascular constriction is vasodilator. Mainly amlodipine, calcium channel blocker is a good drug for this purpose. Next question. A 72-year-old man with documented NSAID-induced peptic ulcer and H. pylori negative. He must continue the NSAID for arthritis. Which of the following is a specific medication for ulcer healing and prevention of future ulcer? The question is about the specific drug used for NSAID-induced ulcer, which can be used for treatment as well as prevention for future ulcer. So in this patient, definitely you will not use the aluminum hydroxide, that is just antacid, that is relieving the burning pain only. Sucralfate is the drug which is also not suitable for this patient because sucralfate is not helping in preventing the future ulcers. Pantoprazole is a good drug, misoprostol is a good drug. But in NSAID induced, the specific drug which we give is the misoprostol because that is PGE1 analog. And in NSAID induced peptic ulcer, what happens? They decrease the prostaglandins. So we replace this prostaglandin. For treatment, pantoprazole is best drug. But in this question, they are asking the specific word. So specifically for these patients, misoprostol we give. So with the NSAIDs you can give so that you can prevent this ulcer, also helping in the healing and to prevent the ulcer. Next question. True regarding colchicine are all except. So basically they are asking the false statement about colchicine. So let's see one by one. Act by inhibiting the granulocyte migration and inhibiting the release of chemotactic factors. True. It inhibits the chemotaxis. It inhibits the M phase. It is good anti-inflammatory. It is wonderful drug for refractory gout patients. Very strong drug. Dose limiting side effect is bone marrow suppression. That is also true. Because of bone marrow suppression, it is not given for all the patients, only reserved drug for the resistant cases. It can be used in Mediterranean fever, yes, that is also neutrophils high level, so you can use colchicine. Used for chronic, no, it is not for chronic, it is used in the acute condition. So colchicine is not for acute, not for chronic, it is for acute condition. So the answer is D. And the important side effect of colchicine is diarrhea, but the specific side effect of colchicine, the dangerous side effect of colchicine is bone marrow suppression. That's why risk of secondary infection. So it is for reserved drug for the resistant cases. First choice is NSAID. If NSAID is not able to control, then colchicine. And the last resort is steroid in acute condition. Patient suffering from pain in right first metatarsophalangeal joint, you can suspect the gout. He was prescribed the drug allopurinol. What is the mechanism of action? Already discussed, allopurinol is a xanthine oxidase inhibitor. Allopurinol and febuxostat also. Febuxostat is non-purine. Allopurinol is purine analog. Uricase. Uricase is like RAS uricase. That is the urate oxidase. Uric acid oxidase. Increase excretion, that is uricosuric drug like proben acid. And chemotaxis decrease, that is like colchicine. So the first xanthine oxidase inhibitor, that is allopurinol, febuxostat. Next question, which of these is true regarding ergot compound? True पूछा है. Methyl ergometrin is used to control PPH. Yes. Methergine can be used to control the PPH because they cause the contractions in the uterine muscle. So they can control the PPH, but not a first choice drug. First choice is oxytocin. Oxytocin is the first choice because oxytocin relaxes the lower part, not causing contraction in the lower part. But ergots cause the contraction in the lower part as well. That's why they should not be given till the broadest part is out. The one shoulder is out, then only you can inject, otherwise not. Usually we inject after delivery. Ergometrin not used in induction of labor because of risk of dystocia. Yes, ergometrin not used in induction of labor because of risk of dystocia, that is also true. तो थोड़ा wrong हो गया question. Not used in induction of labor because of risk of dystocia. Yes, that is also true. Bromocriptine causing hyperprolactinemia? No, it is used to treat the hyperprolactinemia. It is one of the D2 agonist. It can decrease the prolactin secretion, so it can be used to treat the hyperprolactinemia. LSD causing withdrawal symptom, that is also false. LSD is hallucinogenic drug. It is causing hallucinations, not dependence. बट इसको थोड़ा चेंज कर सकते हैं, फिर आंसर निकल जाएगा. तो methyl ergometrin is drug of choice to control PPH. Now you can say it is false. It is not the drug of choice. Oxytocin is the drug of choice. So option B. Ergometrin not used in induction of labor because of dystocia, that is true. Remember, ergot compounds are not a choice in induction. They can be used in PPH but not the drug of choice. Ergot compound should not be used if already the patient is hypertensive, stroke, ischemic heart disease, because there is risk of vasoconstriction. I told you ergot compounds causing vasoconstriction. Migraine में पढ़ा. Next question is all are true regarding prostaglandins except. तो आपने नोट किया which topics are important in autocoids? Antihistaminic, then drug for migraine, drug for gout, drug for rheumatoid arthritis, NSAIDs, especially aspirin, paracetamol, then some prostaglandins uses. These topics frequently asked. So all are true regarding prostaglandins except carboprost used in MTP and to control PPH, that is true. Carboprost is PGF2 alpha, and that is used for MTP and PPH, but not safe in asthmatics. In asthmatics, it is contraindicated. PGI2 causing platelet anti-aggregation, that is also true. Thromboxane causing aggregation, PGI2 prostacyclin causing anti-aggregatory. Gamiprost is PGE2 analog, that is false. Gamiprost is PGE1 analog, not PGE2. PGE2 is dinoprostone. Dinoprostone is PGE2. Also not to be confused with the dinoprost. Dinoprost is PGF2 alpha. So dinoprost is different, prostone is different. It is used for cervical ripening. Yes, that is also true. तो gamiprost, ये वाला ऑप्शन रॉन्ग हो गया. I told you misoprostol, carboprost, gamiprost, dinoprostone, all these are the prostaglandins. So we should have idea about the prostaglandins as well. The last question is, all are true regarding acetaminophen or paracetamol except N-acetylcysteine used in overdose. True. Antidote. Analgesic without anti-inflammatory. Yes, least anti-inflammatory effect is there. Causes sterile pyuria. Yes, that is also true because it is also causing some renal tubular damage. So there will be pyuria, WBC pass in the urine, but sterile, it is not causing infection. Non-sterile pyuria, bacterial pyuria, that is in the UTI. All these NSAIDs are nephrotoxic, they can damage the kidney and there will be pyuria. Phenacetin is the active metabolite. No. Phenacetin converts to paracetamol. So PCM is the active metabolite of phenacetin, which is a prodrug. So PCM is the active metabolite, not phenacetin. So this is about the acetaminophen. So all these topics are important in Autocoids. Please revise. These are my Instagram and Telegram group. You can follow me to get more details, more questions, and you can join our second year course. We are helping you while taking these classes so that you can complete that topic. You have the target, and after that we discuss some MCQ so that you can see your preparation. That's all. Thank you. Bye bye. Take care. Namaskar.